Well, thank you very much, everybody, to joining us for TICAD8 side event, hosted by the Pediatrics Department of Oxford, Aston University, and 𝗔𝗲𝗏. So first session is going to be a talk by Professor Georg Holländer of Oxford University. And George, because you have so many titles, can you introduce yourself, please?
Yes, so my name is Georg Holländer. I have been trained as a pediatrician, then worked in the United States, in Switzerland, and now in the UK, both as a pediatrician, but also as a basic biomedical researcher, interested in how the immune system develops and how the immune system works in cases of the challenges for which it has been designed, namely infections, cancer, and other needs to fight off potential harm. I'm presently the head of the Department of Pediatrics in Oxford, which is a department of around 350 people, who you might have heard is and was very instrumental in carrying out all the clinical research that went into one of the world-leading vaccines against COVID. I'm at the same time also the director of a Center for Child Health, which has aspirations to provide healthcare solutions, new insights in diagnostics, disease projection, and therapies for young people, particularly young people in low and middle income countries. So that is basically the kind of titles, Koji, that you were referring to.
Yes. And today I want you to discuss about the digitalization of healthcare sector, how digitalization can leverage what science and the other science has been done in the medical sector. And so could you start with the benefits for both private sector, government, and public health side?
Yes, gladly. So if we look at the opportunity that electronic medical records provide, and also the challenges, then I think we can look into first, what is the definition of it? Then we can look what are the benefits of such medical records globally, generally for the patient, for the institution that provides the healthcare, and then obviously also for a healthcare system, including a Ministry of Health in providing guidance where particular public health needs need to be addressed. And then probably we should also talk about, as I mentioned, the challenges. So if we look at the definition of electronic medical records, then the most simple form of the definition is it is a repository for active notations about a patient's health. So you have here already the notion that something is recorded, and we can talk later about what is recorded and how well do we record it, and how likely it is that the recording is not only for the individual, but for a whole system valuable. Then we have the patient, the individual, and his or her health, or past medical records. And then obviously we also have issues with that relate to how do we store this data and how do we keep this data. But talking first about the benefits, I think there are 5 levels of benefits we should consider. It's the patient, the physician, the provision of medical support, such as the pharmacy or any other infrastructure of the hospital, then issues of public health, and then probably again, the hospital per se managing the services in healthcare delivered to the patient. So what we know from electronic medical records, as they have been implemented initially, mainly in the global north, is that they result for the patient in shorter hospital stays and lower costs. Now, how come that? Why is this explained? How does that happen? Because you have a medical listing of diagnoses that have been done in the past, of results that are recorded, it is faster for staff to access this information and compare it. Typically for doctors, it's not the moment per se alone that is relevant for a diagnosis, but it is also what has happened before and what was investigated before. So here, if you have access to information, the time to make a decision can be shorter. The lower costs come obviously with lower time in the hospital, and both of these factors actually also hold true in low and middle income countries, where, for example, if you think of situations where a hospital has not enough physicians that look after the patients, where a patient-doctor contact is not once or twice daily, but probably only every second or third day. So the more information you have at one moment, the faster you can make a diagnosis and a treatment plan. The second thing that has clearly shown is electronic medical records, particularly if they are connected to a knowledge system, prevent mistakes. Mistakes that come, for example, from oversubscribing, having interactions between different pharmaceutical products in a patient, or not giving the medicine in the right sequence. So here, I think medical records have the advantage for the patient to be clearly profiting from right dosing and the right medication. What it also allows is, if you think a little bit further, is that patients can be better followed up. So if the system knows that a patient would need to be seen in 2 weeks' time, then a reminder can be sent to the patient, and the patient can then easily be made aware of that his next appointment is in a couple of days and he's expected to be seen. For the physician, having access to medical records and a medical information system, the benefits are the following. The first one is, I think, first and foremost, the care plan. So they can better organize what kind of treatment is to be chosen, not only immediately in the hospital when the patient is seen, but also over time. And so it is important that patients' care plan is well planned, particularly if they are not in the vicinity of the hospital anymore. It provides, as I said before, references, and it helps basically to have access to past medical examinations, lab results, radiographic results, physical examinations. And all this, and this has been, I think, impressively shown, all this results in fewer mistakes and therefore in better learnings and consequently in safer medicine for the patient. Probably for the three other points, namely the pharmacy and public health and hospital management, let me just give you for each of these 3 points to 1 to 2 hinters. For the pharmacy, one of the bigger problems is, how do I know which medication is usually used? If I'm a small pharmacy somewhere in the rural area, I want to have some kind of a record of how I have and what I have dispensed. And so for supply chain management, it becomes a very important tool. The other aspect is the pharmacy usually knows for one patient, even if he or she has seen various doctors, which medicines are being prescribed. And so sometimes, as you all know, some of these medicines actually, when given to the same patient, can have interacting actions, which can lead to side effects. So here, again, a safer prescription is possible. For the public health situation, it's fairly obvious that if you can record what kind of diseases and how many patients have this kind of disease is recorded and is accessible as information, then this becomes a tool by which public health organizations, being governmental or non-governmental, can respond. And if we go back and think about a very early and very first kind of public health reading of an emerging infection, where observations in the United States, where people started to use Google and Google searches to find out who has looked for an answer to question, what shall I do if I have the flu? And all of a sudden you can see how the influenza infection as a typical, event in a colder season is moving across a country, and it is really mirrored 1 to 2 days before the diagnosis is then done and available to the public health organizations by just looking at, for example, what can I do against headache or fever? So for public health disease management, surveys, assessment of success also of public health measures, medical records that are electronically available become very helpful. And last but not least, for the hospital will be absolutely in a better place if they were able to have a electronic medical record system, because then they can provide the support, the management, and the workforce to those activities that they see are at the moment needing most of the attention. So I think these are at least in my box, these are the 5 most important benefits.
Thank you very much, George. I just wanted to ask you the question between how doctors and hospitals are resisting to share private data, which in your mind to belong to the patient, so that patients can utilize their medical record for their healthcare. So for example, you mentioned before the COVID that public spending for healthcare in Switzerland is astronomical, so as US, and I guess Japan too. So I think that in order for the people are talking this Web3 to taking their private data out of GAFA plus Microsoft to their own, to taking care of yourself, I think healthcare is one of the most important area, I would think. And the law for who owns the medical data is always very ambiguous, because general practitioners, they think, because they wrote the data, they wrote it down, the copyright belongs to them. But the patient, of course, thinks that this is their privacy data. So I think that these things are complex issue. Well, what do you think? You mentioned that maybe the hospitals has upper hand because they say they want to have the data inside of firewall. But of course, now our technology advanced so that even that within the firewall, we have a technology to share with each patient. So do you have any view on where the ownership is going to belong and how this Web3 initiative is going to affect the electric health records?
Very complex question, Koji, and a very interesting one, and probably one that very much differs whether you look at the needs and possibilities in the global north, so in industrialized nations, or whether you look in settings where resources are limited, or actually where resources are barely available. I wish, and probably this is the best way to start to access this complex question. I wish it would be possible in the future, and I know this is technically feasible, that everyone is the owner of their own medical data.
I agree.
I think it would be, excellent if patients were the keeper of this data. But for all of us, we do recall having put something somewhere and then it's not there anymore. And we get into panic, where is it and who has stolen it, until we realize actually nobody has stolen it, I just misplaced it. So this is in the nature of human mankind, that we are sometimes more, sometimes less well organized in placing things. But from a clearly organizational and operational point of view, it would be ideal if all this medical information were to be safely stored and accessible for a physician or any other organization. And I'll give you a very simple example in a second, to have access to this information as approved by the patient. Mm-hmm. There might be things that the patient has all the right to say, no, this is not accessible to Mr. X or Dr. Y. So the example here I can give is, if you have had a mental health crisis, but that's in the past, and you now go and see a dermatologist for a skin disorder, that dermatologist does not need to know whether you have had a mental health crisis. So the patient should be ideally in the driver's seat to decide who is allowed to know what. We know that physicians are compelled by law to keeping the privacy of patients and his or her information intact. But again, I think a double layer of security and privacy control would be very helpful here. If you think along the lines of what we all now do, particularly those of us who need to travel, we travel and sometimes at the border somebody asks us, pre-COVID, have we had a vaccination against yellow fever, for example? And we used to show it with a little yellow booklet published by the World Health Organization. That can also be made now much, much simpler, because you then have a very personalized public health relevant record available to show to the border authorities, or if you enter a building or whatever we have now become very accustomed with COVID and COVID vaccine. So I think here the individual can, should, and must be the owner of the information. Now, how can we make sure that this information is not being lost? It could very well be that one creates an offsite repository for this information where continuous updates are being made. This is technically, I understand, possible, not always that simple, but can be done and must be done, again, under the conditions that the patient has the right to control what is being put into the publicly accessible record. The hospitals and the physicians should be, however, empowered to provide all the necessary information and all the relevant information to such a repository. Why do I think this is important? Just think of the situation where a family moves from one state or from one country to another one, and the transfer of this information is either a very tedious thing that the physician has to do and summarize all the medical records and everything, or now would be so much better with a electronic medical record to just basically give a set of data in the cloud, via the cloud, to the patient, who then can store it safely through a system. So I think for the global north, this is highly relevant. For the global south, where a lot of the records are very scarce and typically kept on paper, and when the paper is lost, all the records are lost, the possibility of even a simple form of an electronic medical record system will provide the opportunity that this information, if gathered correctly and stored correctly, and that doesn't need to be even via the cloud or off-site, but even locally in county hospitals, that this information, important medical information, is not lost. So I think from my point of view, I would see the discussion, who is the owner, from a point of where is the benefit? And the benefit is always for the patient.
Yep. So George, good news is that GV has developed a key system which the patient is in charge, but the depository it can be hospital itself. So you don't really need to duplicate the data. Duplication always delays some data, so there's a discrepancy between data. But in our new system, which each 8 billion people have their own private data key to access to the data in the hospital, and the hospital doesn't really produce a secondary depository, because secondary depository is always a risk to be leaked, and the private data can be leaked much more than just one depository. So that's sort of the way I think that the world is now moving, and this way that it is going to be clear with, so we are compliant with GDPR. GDPR and the other regulations do not want the data itself to move across the country, but because we are only dealing with sophisticated key management, so key itself doesn't really have any privacy data. This is going to be compliant with GDPR, so therefore that it's achieved two bars in one stone.
No, that's a very important point, and we have talked about this in the past, Koji, and I think this is a very convincing and elegant way to avoid a number of Achilles heels in a system where generally people are concerned about privacy and safety. And it's interesting for me to see that people are very, very particular when it comes to the privacy within the banking system, that they keep their private financial situation very close to their heart. But in other measures, such as health, they seem to follow a kind of a different set of references. But when we look about the different systems and you interview people, what is important if I adopt an electronic medical record system? Then, particularly if you look in, let's say, sub-Saharan Africa, the interesting part was always for me that safety and security was one of the major points that people wanted from a system. Other points, and that speaks to just what you said, was how easy is it for an individual to become proficient in accessing the system? So anything complex is going to be difficult to be adopted. And so quick user proficiency and a friendly interface have been named as one of the major drivers, actually the major driver for adopting a system. And user satisfaction, interestingly enough, is 5 out of 5, the least important factor when physicians and nurses and pharmacists were asked. At the second point of what seems to be important is, as I mentioned before, is a system built in the medical record system that does comparisons, that allows, for example, to include treatment guidelines. So that also teaches basically the physicians in what the standards are, that you don't treat X with Y, but you treat it with Z, for example. It needs to be intuitive. That was another very important point. And it should delay, or it should reduce the burden on patients and the healthcare provider. So you have a number of characteristics, and of what you just pointed out, it basically all is reflected in how simple can I make it, that a system that is very bespoke for a particular country, for the economic possibilities of that country, with regards to the complexity of the electronic medical record. How easily can I work with that record? And if I can have a simple way, as you described, and as GB has developed, that would be clearly highly beneficial.
Yep. The user friendliness comes from the smartphone. Smartphone can have a now good camera and microphone, so it is easy to recognize whether you are the actual patient who can have the authority to have the key to access to the data. And so smartphone and the cloud is a two key development which has done last 20 years. And I think that with these, that you can make it much easier rather than people trying to remember the password and ID, which is so many now, so people can't really remember. But now our system is with the smartphone recognize you with a different shape of a face or voice and the mixture of it. It is very, very secure to have that one. And then you don't really need to remember the long keys, which a human cannot really remember. So that's the sort of sophistication as well as user friendliness we are incorporating.
I think this is indeed recognized that, you know, these PDAs or any other kind of possibly phone-based electronic device can actually provide much more privacy, clearly much more privacy than having it written on a piece of paper that Absolutely. Somebody then has to file. And if somebody has forgotten to lock the room where all the files are, you know exactly what's going to happen. Yeah. So I think on that level, privacy is more easily set up, but it also provides with the same device, namely the basic unit, to store information.
Mhm.
And these days, you know, not all, a number of phones that are also available in low and middle income countries can do that now very easily.
Yep.
If it's only, you know, a message-based system of communication, that gets very difficult to do that. But I think a lot of countries in low and middle income settings have basically invested in telecommunication possibilities that allow PDAs to be some kind of a simple recording and storage device for this information. So I'm actually very positively looking forward that this and the overall driver of costs coming down will be an additional argument why electronic medical records also in the global south will have its value. And here, just in preparing for today's session, I came across a paper from Malawi that answered or addressed and in part answered a number of the concerns that I think a lot of people had initially when they thought about electronic medical records. It's too expensive. It depends too much on technology, including electricity and constant electricity supply, and it requires you know, human resources that will make it very difficult to not see that anything but a loss-making activity. And so in a hospital in Malawi, with the support of an academic group from Pittsburgh, they looked into the way how establishing a local electronic medical recording system had changed. And they had an initial investment, and this was 10 years ago, 9 years ago, of approximately $340,000. But looking at the benefits of it, being from shorter hospital stays, better supply management of the pharmacy, faster decision-making, no duplication of tests because they were available. They had them on the tip of their electronic fingers. No unnecessary lab examinations because you didn't have past medical records. They basically could show that the expenditure for setting up the initial record system, so the investments at base, that actually this was recovered within the first 3 years. And then depending on how you measure savings, basically up to $500,000 were actually saved over the course of the first 5 years, including taking into account the upstart investment costs. So for me, this was a very important observation that yes, there are a number of technical challenges, and yes, there is an infrastructure that you have to build up. But I think if you take the right factors known now to drive success, you will actually have a system that works, and that is, with regards to the economy and also economy of scales, is actually attractive.
Okay, and let me change subject slightly. It may be a part of electronic medical record, but vaccine passport. You mentioned that yellow fever passport, and now COVID-19, when it was at the height, people have crossed the borders, and now yellow monkeypox, for example. So I think that you mentioned that vaccine, of course, is necessary to distribute globally. And until such time that the last one person is going to be vaccinated, it is not going to be the COVID-19 or COVID-29 is not going to be over. But at the same time, in order to keep the economy going, vaccine passport might be quite powerful. Do you have any view on this?
It's a very timely question, and it's a question that I think many of us have, had a brush with in finding an answer, in contributing to an answer, or in possibly even opposing a measure that was put in place. From a public health record, or public health policy point of view, you obviously would like to have, and I'm very, very convinced about that, everyone having been vaccinated. Been vaccinated to decrease their own risk of getting seriously ill, but also decreasing the risk of handing on the virus to others. So with COVID, we have learned if you've been vaccinated and you have a breakthrough infection, as many of us might have experienced, that does not mean the vaccine doesn't work, because typically these breakthrough infections result in a much, much milder disease. But what they also result in is in much, much less transmission of the SARS-CoV-2 virus to others. And so I would wish to know that everyone is vaccinated. And I would wish to know, possibly in addition, because immunologically that's the best situation to protect yourself, that some of these people have also had a breakthrough infection, as this in the end results in the most robust immunological protection. Now, having that on a record, and having that record linked possibly to other medical information, such as particular risk factors, will make a quick decision of a physician who sees a patient who has now symptoms, let's say, of COVID, but who's also a diabetic, makes it much, much simpler to decide which is the right treatment strategy. For an organization, it could be relevant to know that all of their attendees in a conference have been vaccinated or have had a documented disease plus or without a vaccine that makes it then likely that they don't pass on the virus, or if they pass it on, unfortunately, it is at much, much lower titers. So from my personal point of view, I think it is absolutely relevant to have these passports, to have this information as part of a medical record system that is electronically kept and that is accessible, again, as we said earlier today, to those that need to know without having access to all the other information.
Good. Any audience, if you have any questions or comments, you can put it in the chat box, please. So far, nobody has put in any questions. George, do you have anything else to add? Technical challenge.
Let's look at the bright sides of things, Koji. And let me just, for this part, I'm very happy to answer any questions. Let me just look at a couple of factors with which the introduction of electronic medical records have been linked to have a successful outcome. Mm-hmm. So one is what is the ethical framework for it? So obviously safety must be secured. It must be informative. It must also meet certain cultural standards. As we know, certain nations are much more cautious and thoughtful about any kind of information that would be handed on to a system where they don't have personal control over, while in others, there is a belief that the system is safe and one doesn't need to have particular concerns. So concerns regarding privacy is very important for the success of uptake of these medical records, that these concerns are being addressed. The functionality, we talked a little bit about it, is very important. So it's not only the system's architecture and the function of the system itself, but as we say, rubbish in, rubbish out in sciences. So if you collect the wrong data, you will never be able to use the system fully. So you need to make sure that you're not too ambitious, but that the information that you collect is high quality. So for that, we need to think of what are the best ways to do data entry, that this is not too tedious to an individual, but some of it can be done already in an electronic and automated fashion. And then there needs to be a person who's absolutely responsible for the system. And the more people are involved in these systems that believe in the system, in, let's say, electronic medical records, the more successful it will be. So you need champions in place that follow, you know, the development and the success of it, and make sure that glitches are quickly taken care of, which leads to the organizational strength. And here, human resources are very central. You want to have adequately skilled staff that are properly trained and that are encouraged to use the system under the guidance of the project management. So having this in place has been shown both in the global north as well in the global south, and that this is absolutely important. And then if I may just go back to the political level, with the political level, it's trust and the attitude to change. If that is not given, then implementing something new that is so far removed from taking a pencil and a piece of paper will have its own challenges and is likely, I think, to fail. So stakeholder buy-in, both at the political and at the managerial, and last but not least, the personal level, is very important. And the technical things and the training things, you know, the other aspects that we need to think of. So in general, and this was the topic I think that we wanted to discuss today in part, I truly think electronic medical records are not only nice to have, but absolutely essential to create, establish, and use, be it in the global north or the global south.
So George, I have two other topics I want you to expand. One is you mentioned about how fast medicine times, let's say, computer science can contribute it. For example, genome or sequencing example, the first person, you need to have billions of dollars for 30 years or something, and then now you can do it. The other one is, I want you to explain to the 54 African nations what you are doing for IDRM. What is this idea of IDRM?
Yeah.
If you can just do two different topics, but maybe related.
Yes. As with so often in medicine, everything is related. You just need to see the right angle, to take the right angle to see it. So Koji's first question was, how is modern technology, in particular, the knowledge of the DNA sequence, so basically the hardwiring of every individual's life risks, trajectories, as biological determinants, how informative is this and how has this developed? As Koji said, when I started medicine, one of the biggest breakthrough was that the human genome was sequenced. The costs were well above $1 billion US, and it was one individual as DNA that was sequenced. Now, if your physician needs it, if you even personally want it, you can have your whole genome sequenced for less than $1,000. This has advanced medicine enormously because, as I said, the hardwiring of the biological system, all that information is stored in the DNA and in the interpretation how the DNA is read. And this information becomes relevant, for example, when we want to choose the right drugs to treat a disease, or even when analyzing a disease, because diseases can look alike, but are driven by different mechanisms, disease-causing mechanisms, and these are best understood by looking at the hardwiring of the cell, namely the DNA. So what might look the same might have different origins, and therefore we don't need to treat the appearance of a disease, but we need to treat the origin, the driver of the disease. So the ability to know which genes are expressed and which genes are not expressed, which genes are changed from a normal variance to a pathological variance, which genes are changed in their expression because there is a, let's say, tumor-provoking mutation. All this has really advanced medicine enormously because we can now understand mechanisms much better, and with understanding mechanisms, we can identify points where we can interfere, either with pharmacological agents or, as we've already seen, also with correcting genetic defects. And as a pediatrician, I obviously also have to mention here that we in the treatment of young people see a fair number of so-called rare diseases, diseases that are genetic typically in origin, and that only can now be properly diagnosed and can be considered for treatment because we can identify the genetic variants and the genetic defects that cause the disease. So this is, I think, leading over to Koji's second question. So what do we do at IDRM? So IDRM is the newest institute in Oxford dedicated to research into the development and regeneration of tissues. So we are all, by the time we are born, we are all formed from a single cell that was fertilized into a very complex organism with different tissues following different genetic programs, resulting in different functions and architecture. So our own body has already proven exactly how we can progress from a single cell to a very complex entire whole being. What the Institute of Developmental and Regenerative Medicine, IDRM, now wants to understand is not only how that program works, how, for example, a heart is being formed in its full complexity, which then will need to last for our entire life. What are the rules, the architectural components, and the way how these different pieces all come together that we have a functional heart? Because once we understand this properly, we can go back and start to look at conditions where the heart doesn't work anymore, either because there was a congenital, so inborn defect that needs to be corrected, or because acquired diseases, such as those of, societal changes in stress, smoking, nutrition have impacted on the function of the heart and now needs to be recovered in function. So the Institute IDRM, which is really trying to, on one hand, understand normal development and then use that knowledge how to regenerate tissues, is really at the interface between medicine, the power of genetics, the competence of creating informative experimental models to test hypotheses, and at the end, the development of new drugs, of new approaches to cure acquired or congenital defects to organs.
Very good. Thank you very much, George.
You're very welcome.
Well, I think that there seems to be everybody was stunned with a lot of information. Probably they are drowned with the information, new information. And I think that if there is no questions, I want to thank George for this fantastic session, the first of our 6 series of the side event online. Thank you very much, George.
You're very welcome. Have a good afternoon, good evening, good morning, wherever you are. Thank you very much for listening in.
Thank you, George.